Okay, hi everyone. We're here today to talk about a topic that is near and dear to some of our hearts and one that we get many questions about, PCOS or Polycystic Ovarian Syndrome. And we have a couple of quick rules and then we want to introduce you to everybody. So one is that this webinar is being recorded. So if you want anonymity, please make sure to change your name. Or you can just do your first name, last initial by clicking the three dots near your name. Please make sure you change your chat to say all attendees and presenters. It defaults to just the presenters, and we want to make sure that you have a question that everyone gets a chance to see it. It's a safe place, so please feel free to, say anything, and we'll try to keep everything, done in a respectful way. And please participate. This is a great time to ask questions. I'm sure the question that you have, a lot of other people have as well, and so we would love to hear from you. Okay. So today we, as always, have a great group, and so we'll go kind of down here in order. And if everybody here can introduce ourselves, maybe starting with you, Dr. Chen, whenever you're ready, after you prettied up there with your lip stuff.
Yes, I have to get my lip gloss on. So I'm Serena Chen, and I'm an IVF reproductive endocrinologist in New Jersey in the States. And so make test tube babies, treat people with PCOS, and I'm really happy to be here.
Awesome. Dr. Mark.
Yeah, hi Monica. Hi everybody. I'm Mark Trollis. I'm a reproductive endocrinologist in Florida. Not as good as Dr. Chen, but I do all of those things. And I am passionate about the PCOS. I'm on the PCOS challenge board, medical board. My book just came out a few months ago on overcoming infertility. And infertility is my life. It's a personal and professional investment that I have.
Great. And can you type the name of your book in the chat for us if you get a chance, Dr. Charles?
Sure. Thank you.
Dr. Braverman is joining us close to 12:30, and so we'll save any of the kind of mental health, emotional questions sort of towards her at the end. And then Tracy and Sarah, do you want to say anything about the expo that we just have or anything before we get started? Sarah is in transit, so it might be Tracy.
I'm hearing you all, and I must apologize because I totally screwed up my diary today, so I'm not meant to be in traffic. But I'm just really, I was just saying before you went live, I am so fascinated by this talk because I myself have PCOS, and there's still so much I don't even know about it. So if I could, I'd be writing notes down. But I'll let Tracy talk.
Hi, I'm Tracy, sort of one half of IVF Babble. The reason we set up IVF Babble was because I myself went through 10 years trying to get pregnant, and it took a long time to get diagnosed. Eventually, when those issues were dealt with, I went on to have my beautiful children. The same for Sarah, her journey was 5 years, and as she says, she had PCOS, and so we're hugely interested to know what everyone's got to say. So thank you for joining us.
Yes, we're so excited. So I am Monica Mormon, nurse practitioner from the States. I do some health coaching as well, and I also personally have PCOS and a special interest in that, both as having it and as a nurse practitioner that talks about kind of what it is to manage it and how it feels to kind of for it to be a little bit different than maybe somebody else your age or that doesn't have it. So maybe one of the doctors could go over us, and feel free to use the picture or not. It's a little bit of a busy picture, but I do think it has some important, hormones and physiology on here for us to first of all talk about, the process of normal ovulation. Just simply said, what needs to happen normally every month for us to get regular cycles?
I call Dr. Trollis.
Well, thank you, Serena. And I was going to ask you. So you gave me the hard one. So to understand the hormonal imbalance of PCOS, we have to know what is normal. Okay. So what's normal are cyclic rhythmic signals from the brain to the ovary that allows for two things. One is hormonal production of the ovary, as well as choosing that dominant egg in a follicular cyst, or called a follicle, okay? So every month, hundreds of those follicular cysts are trying to get to be the dominant one, and only one makes it, the rest die off, okay? So the signals from the pituitary gland, where FSH and LH, signal the ovary to get a dominant follicle to grow and release an egg. So FSH stimulates, follicle stimulating, and then the trigger, the natural trigger to release that egg is the LH surge. And that's what's detected in a woman's urine. When she uses an over-the-counter ovulation petition kit, the urine detects that elevation in LH, and that lets her know that she'll be releasing an egg usually within 24 to 36 hours. PCOS, none of that is happening. Well, actually, you know, you can be having sporadic ovulation. 20% of PCOS can even have monthly cycles. You can be bleeding monthly, every few months, once a year, never or every day. PCOS is just chaotic because the signals from the brain to the ovary are not synchronized. So what's happening is just sort of a steady state, if you will, just a steady stimulation of hormones that are just being secreted in low amounts from the ovary, and no rhythmic signal that eventually gets that dominant egg. Now, when I mentioned LH earlier, there's two different subtypes of PCOS that have just been described in a journal, PLOS Medicine, where Andrea Dunafe and Dr. Richard Legro. So some have higher levels of LH, okay? And those higher levels of LH can cause a false positive reading when a woman is checking her urine for ovulation. So she may call and say, you know, I'm testing and every single day it shows I'm ovulating. How can that be? Well, because her LH is higher than normal, and it's being picked up in the urine. So she's typically not ovulating, and the way we can determine that is by a progesterone level, okay? If the progesterone level is elevated, usually a week after that color change, then it shows that she's ovulating. If not, then she's obviously not. So the most common reason for a woman not ovulating is what we're talking about today. PCOS affects 6 to as much as 20%, so almost 1 in 5 women are experiencing this problem. And it's the most common problem with ovulation dysfunction, probably the #1 reason for infertility, or at least certainly for not ovulating with infertility. And we see this more than anything. The last question about birth control pills that's on the screen, interestingly, being on the birth control pill can actually help restore hormonal balance, not just while they're on it, but temporarily coming off it. You know, I see a lot of patients, I'm sure Dr. Chen does too, that PCOS, they have a first baby, and then they have trouble having the second baby. And what's the difference? Well, they were on the birth control pill from their teenage years because their periods were all over the place. And so after 10 years of birth control pills, they come off it and they're ovulating for a few months, and they get pregnant within that first 6 or so months, okay? Then after baby, they don't go back on the birth control pill because they want to have another baby in a year or so, and then they're not ovulating. So the birth control pill is not really a punishment, if you will, when we tell our patients to go on birth control pills, even to get pregnant, because it helps them ovulate, even for a month or two being on it. If we're having trouble getting them to ovulate, going on the birth control pill can actually help.
Yeah, it can be like a reset. And then also for the second baby, you're older for your second baby than for your first baby. So it definitely can be harder, because some PCOS patients will pop off an egg every once in a while. And as you get older, you know, harder to get pregnant with that occasional egg than when you're younger.
So that's so interesting in terms of the bleeding each month, right? And so annoying for all of us who are trying to figure out. So if we have, you know, abnormally positive urine ovulation predictor kits, our bleeding is sporadic or monthly. So in terms of how we know if we're ovulating, let's say we're somebody that's pretty early on in the fertility journey, and we're trying to figure out if we need to see somebody or not. What would we be looking for pretty early on in terms of from day 1 to day 1, over how many days, like over 35 days, should we start seeing somebody? What's kind of like, when should we see somebody as opposed to when can we try on our own?
So the normal range is supposed to be 25 to 35 days. So anybody whose cycle from day 1 to day 1 is longer than 35 days is considered to have oligoamenorrhea, which probably means maybe you're not ovulating, or you're not ovulating as regularly as you should. But I would say that even if you're regular, I think anybody who has questions or concerns can benefit from getting checked out, talking with their doctor, either their OB-GYN or maybe even considering a specialist, because I do think that for PCOS and for everyone, pre-conception health, there's a lot of good things that you can do to set yourself up for success. But then the range is 25 to 35 days is like kind of where most people fall. And if you're outside that, something definitely could be going on with your ovulation.
And what I will say personally, what I noticed with mine, and I don't know, Sarah, if you had the same, but I could never tell when my period was coming. Like a lot of people would get maybe pimples, some breast tenderness, moodiness, sometimes
I wouldn't get anything
in the middle of nothing, and
Yeah.
4 times a year, and be like a disaster, both in terms of pain and bleeding and everything.
And do you know what's so sad? Girls, can you hear me?
Yes, I can hear you.
Yeah, you can. Oh, yeah. Do you know what is so sad? That I never, ever had any clue when my period was coming. That even on my wedding day, I was so terrified. I actually had to wear a tampon because I thought, what if I suddenly get my period in the middle of my wedding? I mean, that's how awful.
Right.
Isn't that terrible? Sorry, was that too personal?
That is awful, and you shouldn't have to think about that. Like, even if you're not trying to get pregnant, you know, people can get help with those things, and that's extremely disruptive, and yet I think most women are just think they're just supposed to deal with it, and that they don't deserve to have help or advice, and that's just not true. So I'm so glad. That's why I'm so glad we're doing this. Is that, like, hopefully just getting that, just opening up the door and saying, let's just talk about this in the open, I think is so helpful. So we're really grateful to IVF Babble for doing that. The other thing is that I always find very interesting with PCOS is that you often start out with very few periods. Then then when you switch over to having periods too often or too heavy, that's when we start worrying about pre-cancer and cancer. And I think people need to know that this is not just about having babies. This is about being healthy, because your risk for cancer of the lining of the uterus is much higher than the rest of the population. So the regulating the periods and making sure that estrogen and progesterone are balanced are really critical to preventing cancer. And so it's not just about convenience or worrying about when you're bleeding or getting pregnant. It's a very important general health issue. And as Dr. Trollis was saying, the birth control pill paradoxically can help with fertility, but the birth control pill also basically eliminates the risk for cancer in people with PCOS, and can lower the risk for ovarian cancer in everybody. So I think the birth control pill or things like it tend to get a bad rap, but in PCOS can really offer numerous medical benefits, and we're only talking about a couple of them here. So I really want to urge anybody who says, you know, my period's a little bit irregular, even if you're not trying to get pregnant now, you really should be regulated. Try to figure out what's going on so you can, you know, kind of take charge of your health, whether you want kids or not.
Just to follow up on that, absolutely 100% agree with Dr. Chen. There are 2 risk factors for endometrial precancer, which is called hyperplasia or cancer. And a study in the Green Journal, which we call Obstetrics and Gynecology, showed that if the interval between periods is more than 3 months, that's a concern. Or if on ultrasound, the lining of your uterus, the endometrial thickness is more than 7 millimeters. Those were the 2 significant risk factors. Now, this is for obviously for patients who don't ovulate or are ovulating sporadically. Who is at significant risk even with those kind of things are the patients that are overweight. You know, half of patients with PCOS are overweight. And when you are overweight, your body is making too much of the estrogen hormone. Now, estrogen comes in different forms. We know the main one from the ovary is estradiol, but in the outside the ovary, which are in the adipose tissue or the fat cells, they make estrone, which is a weaker estrogen, but in high amounts, particularly in patients who are overweight, right? So the higher the amounts of that weaker estrogen, it still can have a powerful effect on the lining of the uterus, making it thicker. So, and of course, weight, unfortunately, has the risk factors of the metabolic syndrome, which now we're bringing up this situation with weight, I think is important. And I want to underscore the point of that the metabolic syndrome affects PCOS women 4 to 5 times more than the general population. And what is the metabolic syndrome? Well, it's a constellation of these diseases that hang around together, okay? Increasing abdominal circumference for women above 35 inches, okay? Elevated blood pressure, elevated blood sugar, a low level of good cholesterol, which is HDL, okay, under the 40 or 50, and the triglycerides being above 150, okay? So they come together. And so PCOS is not just, as Dr. Chen was saying, a reproductive problem. It's actually a medical problem as well, because after your reproductive years, you're still going to be at risk of the diabetes and the high blood pressure, as well as obviously the uterine cancer, what we talked about. These patients have depression and anxiety at higher rates as well. So it's not just about reproduction. Lots of women are suffering through all of those other things. And really the only thing that they can potentially improve is if they are overweight. Patients who are thin can still have these issues, but it's certainly worse with patients with an elevated body mass index.
And say thank you, Dr. Lee. So then if we compare, like, and kind of contrast these 2 pictures. So this is the kind of clinical picture with PCOS. 2/3 of women with PCOS, like you explained, are often overweight or obese in a higher BMI category. And the difference in this picture are a couple of things. So the addition of these fat cells increases a hormone called leptin. And what that can do is make somebody insensitive to leptin. And so people with PCOS, and I can attest to this, often feel hungry when they quote unquote shouldn't be hungry, don't feel full. The way that we eat and the way that we kind of manage what we eat is going to be really different than our other friends who don't have this issue. The other thing is there's an elevation, and we'll talk about this in the next slide, of insulin or an insulin resistance, which can cause hyperinsulinemia. How does that excess in insulin or the hyperinsulinemia or insulin resistance affect people with PCOS?
Well, that's a very important point. You know, years ago when I was training, and probably a little older than Dr. Chen, I'm sure, but when I was training, we didn't know, or the debate was, what comes first, elevated male hormone or elevated insulin, okay? And it shows that in elegant studies that elevated insulin causes elevated male hormone. Before we go too far, I just wanted to interject. Women need to know how to diagnose this, and you actually can diagnose this at home if you have 2 out of 3 criteria. Okay, so the consensus seems to be having those criteria using the 2 out of 3. So ovulation dysfunction. So either you're not ovulating even though you're bleeding monthly, or your cycles are more than 35 days apart. The second is that you have some measure of elevated male hormone. So that's either an elevated total testosterone or a clinically significant male pattern hair growth. Okay, so where is that? Upper lip, chin, sideburns, neck, chest, around the breast, lower belly, lower back, upper inner thigh. And not just the sporadic hairs. It has to be a reasonable amount of coverage. And the third is ultrasound, okay, as Monica is putting on the screen. All those little black circles in the bottom right part of that ultrasound, all those little black circles are completely normal. They represent those follicular cysts that I was talking about earlier that have microscopic eggs. But for some reason, women with PCOS have a lot more of those than women who do not have that. And there is a criteria that having at least 20 of those little follicles, less than 10 millimeters, 20 of those or more on at least one ovary, or a volume of the ovary more than 10 centimeter cubed, makes the diagnosis. So you're not having ultrasound at home, but you can do the first two diagnoses of having the ovulation dysfunction and the hair. And that's important that you realize what's going on. I want to just do one quick point about hair growth. A lot of women think that they are growing hairs. And so the issue about the hair growth is that women of the same race and ethnic background have the same hair follicle distribution as men, okay? What is different are the dark hairs or the terminal hairs, okay? So what happens when elevated male hormone comes about is that it stimulates the dermal papillae in the hair follicle to grow the terminal hair, from soft hair, vellus hair, to terminal hair. So you're not growing new hairs, you're changing the hair that you have. They're being converted from vellus to terminal hair. Once the hair goes dark, that's it. It's always going to be dark, okay? Unless you do electrolysis or laser. But don't do that until you try to stop that conversion of the vellus to terminal hair. And how do we do that? Well, as Dr. Chen earlier, the wonderful birth control pill, that can stop those abnormal signals and reduce the increase of male hormone. That, and there's also some anti-male hormone medications that are called spironolactone. And if you're on these medications for about 6 months, you should be able to stop that conversion. And at that point is when you can start doing the electrolysis or the laser. If you do it without any hormones, you're going to be doing a turnstile in and out of the electrolysis and laser centers continuously because you're not doing anything to stop the hair. Okay.
So now we've seen that the birth control pill can, when you start it and then stop it, can improve fertility. It can reduce the risk for ovarian cancer and endometrial cancer, and it can reduce your androgen levels, which reduce one of the symptoms of PCOS, excess hair growth, and acne. I think Dr. Trollis mentioned very importantly that they're with across ethnic backgrounds, hair is the same between men and women. When you think about ethnic backgrounds, you also have to think about Asians tend, compared to say Mediterranean, people with a Mediterranean background may have a lot less hair, so they might not get some of these symptoms. I would say that if you chronically have irregular periods all the time, like since you started your periods as a teenager, the number one diagnosis is PCOS, even if you don't have the other things. Now, there can be, I think Dr. Trollis probably agrees with me, there's a wide spectrum for symptoms of PCOS. There are some people who have no symptoms, and yet we think they might still have PCOS because of the way their ovaries look, because of the way their ovaries behave. But those people you can't diagnose until they, see a specialist. But for people with irregular periods, that's, in the reproductive age group, if that's been going on since you were younger, since you were a teenager, that, 9 times out of 10, that's got some form of polycystic ovarian syndrome. So, and I think women are very good at diagnosing themselves. I think, I see a lot of people who have been suffering for years, and, they go to see the OB-GYN and nobody tells them that they have PCOS, but they kind of know it. And we end up confirming it as specialists because general OB-GYNs, at least in the United States, I don't know how it is in the UK, but in the United States, general OB-GYN is very brief. It's aimed at get your pap done, get your birth control, boom, in and out, and not much about like understanding, a lot of what's going on with you. So I think general OBGYN training doesn't tend to emphasize that. So a lot of people do end up frustrated that, that they don't get this diagnosis earlier, because we have a very kind of reactive disease-based system as opposed to a proactive system, which is why programs like this are so important, because all of us on the panel today really strongly believe in people, empowering themselves with knowledge so that they can, advocate for yourself and raise the bar on your own health. So we're so glad you're here.
Yeah, there's a good portion, very well said, Serena, there's a good portion of women that have to wait several years before a diagnosis and going through 2 to 3 physicians. That's been supported in the medical literature. I just want to, for the teenagers that may be listening, or at least their moms, I would use the irregular periods and waiting for at least 3 years. After the first period called menarche, typically women will have irregular cycles, but if they persist after 3 years, then you're starting to get some concern about that.
Yes, so that's a very good point, because you're right. It's very difficult to diagnose PCOS in adolescents, because adolescence is a PCO-like part of your life. So almost everybody goes through some of that as an adolescent. Then there's huge overlap between normal puberty and PCOS. But as Dr. Trallis said, if you have normal puberty, it just, evens itself out after like a few years, whereas PCOS just keeps going.
And ultrasound is not really valid during the teenage years, because a young woman they're all going to look like that picture.
That's very.
I think they just changed the diagnostic criteria, right? So you just had to have 2 of those. Ultrasound for teenagers and PCOS isn't required because it doesn't help.
Right.
Yeah, teenage is so hard as a teenager. So hard, very hard.
So what happened to me, and what happens to a lot of my patients, and Sarah, I don't know what happened to you, is I played sports my whole life, got my period. They became so regular and annoying when I played sports that I went on a birth control pill. No one really talked to me about it, but it was just easy because I went on the birth control pill. It helped. And then I went to college and I went off the birth control pill. I don't even know why, probably because I couldn't afford it. I needed to buy my meal plan or something, and gained like 30 pounds, mostly in my belly. And I was not a belly gaining person before, I thought. The hair growth started. It became, as you can imagine, very embarrassing. And that weight was not, I was eating the same as all of my college roommates, if not less. I just was doing less activity than I was in sports. And I see this a lot. So girls or, women, young women go off to college or they stop dancing, they stop being an athlete doing something, and they have a change in their athletic, kind of parameters or what they end up doing. And then this is kind of any addition of the weight gain, and exercise is so good in terms of sensitizing your body to insulin. So the excess insulin kind of rears its ugly head in those ways. And all those side effects that you were talking about start to either come out or get exacerbated by that. So really, if we're talking about, kind of treating it, which really we're talking about managing it.
Monica, I'm so sorry. Do you mind if I just interject one thing?
Yeah.
I apologize.
Yeah.
You mentioned something I think that is extremely important to do a little bit of a tangent on. And you said that you were very active in sports. The criteria for the PCOS, with the Rotterdam criteria, if you don't have elevated male hormone and you have ovulation dysfunction and an ovary that looks like that, yes, you are technically diagnosed with PCOS, but it is also possible that you have something called the female athlete triad. And that is a condition that has a lack of cycles, ovulation dysfunction or loss of periods called amenorrhea, bone loss, because there's a situation there where you're not making the estrogen like PCOS. The signals from the brain to the ovary are literally absent, and your estrogen level is low, so you lose bone mineral density. And the third is calorie deficit, energy deficit. You're not bringing in enough calories for the energy that you're expending. So it probably takes more of an astute clinician to be able to make the nuance between that, because I have been fooled, and I think that sometimes there's even a mixed component of somebody who was a very active during high school with either dance or gymnastics or other sports or running. And they develop a PCOS condition, but it is very hard for the nuances. And so it's important to make that distinction.
So interesting that you bring that up, because when we're taught in medical school with all these textbooks that these diseases or these conditions are very cut and dry and demarcated, and you and I know from, you know, decades of seeing actual patients that a lot of people don't fit tightly into these categories. And some people even evolve over time, and people deserve to be followed and assessed and addressed over time, because these can be lifelong conditions, and sometimes it is difficult to come up with a definitive diagnosis, which highlights the lack of research and knowledge we have in this area. These are all clinical diagnoses. We do not have a test so common that a patient says, well, I was tested for PCOS and I don't have it. And yet they do have it, because just because all your testing is normal does not mean you do not have it. This is a clinical diagnosis. There's no single test that diagnoses it. There's a spectrum of disease, and there are groups of patients with PCOS who don't have any laboratory abnormalities, and yet they are impacted by the disease. So, you know, I'm so glad you bring that up. And we need so much more to be done. It's like a lot of other women's diseases. There's very little that we know. But at the same time, the athlete's triad tends to be a lot less common than PCOS. So statistically, if you're a betting person, I would bet on the PCOS, just because that's just so common. And, you know, you'd mentioned before, you know, 10% of the population. I'm thinking if we throw in all the skinny people with the high AMHs that you and I are seeing who have no other symptoms, you know, it could be even higher. And I always wonder, I mean, this is a little bit crazy, but I always wonder, what is the male manifestation of PCOS? Are they truly asymptomatic, or are there a lot of guys out there who have the PCOS gene and have zero symptoms because it just doesn't generate symptoms in males, and yet have the insulin resistance that we think might underlie all of PCOS?
Well, I think the metabolic syndrome is a nice tool for the male to give us a suspicion for PCOS. You know, it's multifactorial, which means that a specific gene has not been definitively isolated as a cause, and you know where this comes from. The theory is that some exposure when you're inside mom in utero, that you're either getting a higher level of androgens, the male hormone, or even AMH, which is anti-Müllerian hormone, which we use now for ovarian age testing. So that seems to be one of the factors involved in having PCOS, as well as there's theories that I think Monica put on the slide earlier about stress playing a role in utero. But I think the male is the potential is the male pattern baldness, and the metabolic syndrome is really one way, but I haven't seen much written on that, but it's interesting.
I want to go back to the treatment because we have Dr. Braverman on.
Oh, good.
And I want to go back to the treatment, but I just want to go over this because I think a lot of this is what you were saying.
Hi, Dr. Braverman.
Yeah.
So we talk about why it's so important in the short-term and long-term effects. I guess the one that we just didn't kind of cover is this chronic kind of low level of inflammation, and why, you know, it's so important when you PCOS to get your lipids, cholesterol, that kind of stuff checked. Does anyone want to address that?
Well, that ties into, I think, everything Dr. Trollis was talking about with the metabolic syndrome. In any condition where you have hyperinsulinemia, insulin resistance, decreased insulin sensitivity is considered to be a pretty inflammatory state. So,
you know, what's interesting is that in terms of insulin resistance, a study demonstrated that obviously the least amount of insulin resistance, and what we mean by insulin resistance for everybody watching, is that there is a defect in the insulin receptor to take up insulin to maintain good blood sugar control, okay? So the person who has the least risk of insulin resistance is a thin woman who's ovulating. The worst risk is for the obese PCOS woman who's not ovulating. But this is amazing, that an overweight ovulating woman has about the same degree of insulin resistance as a thin PCOS patient. So PCOS has that much of an impact that just having that, and you don't have to be overweight. So it's important to have your blood sugar screened. And I use a 2-hour glucose tolerance test on most of all of our patients with PCOS. Sometimes we'll do another test called the hemoglobin A1C and a fasting insulin, fasting glucose, and look at that relationship by using a homeostatic model to calculate. But all PCOS women should have some measure of insulin resistance testing because of how common it is. Up to 40% of PCOS patients have pre-diabetes, 5 to 10% diabetes. So if you are without insulin resistance and you're thin, probably just proceed with ovulation induction if you want to get pregnant, or the birth control pill if not. But if you are overweight and trying to conceive, there seems to be some support for metformin, even if you don't have insulin resistance, because it may improve ovulation function and some metabolic factors.
I think it can sometimes be very difficult to diagnose insulin resistance as well. And I tend to feel like almost everybody that has PCOS has some form of it. And Dr. Trollis, are you using inositol at all? Because I've been using that a lot. I'm finding that it's really helpful to my patients to help lower their hemoglobin A1Cs.
Well, I use, excellent question, Dr. Chen. I use the 2-hour glucose tolerance test. The fasting should be less than 100, and the 2 hours should be less than 140. Anyone above either of those parameters, we put on metformin. Or if the BMI is above 30, there's a position paper by ASRM that advocates that. So if we don't get the 2-hour, then I use the fasting insulin, multiply it by the fasting glucose, and divide it by 405 and do the HOMA calculation. And if that's elevated, then we'll consider that insulin resistance, because that's what's been used in research studies.
Yeah, I've been
Can you write
adding
inositol in,
as a
Dr. Chen?
supplement.
Can you type the name inositol in the chat when you're done, Dr. Chen, just so people
Yeah,
can
it's
remind you how to spell it?
inositol.
It's
So
a
because I
supplement.
use that in addition, myo-inositol.
So you use both myo-inositol and metformin?
Yeah, because they seem to work, and we don't know enough. I mean, we don't actually know the exact mechanism of how metformin or glucophage lowers insulin resistance. We just have decades of experience knowing that it does. So it has been well studied. It seems to be safe, but the myo-inositol seems to work via improving the function of the insulin receptor, probably because inositol is a second messenger for the insulin receptor. And so it seems to work by a different mechanism. So it might be 2 different mechanisms to lower insulin resistance. Now, I don't know that there's any formal studies on that. There's separate studies on those mechanisms. And again, you know, so much more needs to be done in terms of research in this area for PCOS. It's a huge, millions and millions of people affected, and yet not enough known. So those are, you know, a couple things to think about, but obviously you should be talking with a doctor about your particular case.
Dr. Braverman, can you introduce yourself quickly for us?
Absolutely, be happy to. Hi, sorry to be late. I was coming from another meeting, but I am a clinical health psychologist at Thomas Jefferson University and Hospital in Philadelphia, Pennsylvania.
Yes, so Dr. Braverman, as usual, is being very modest. She is a very well-known, great speaker on all things mental health and emotional consequences of all kinds of infertility, and where we're talking about PCOS. You know, as we talked about, Sarah and I you feel different than other people your age. Maybe you have an abrupt weight gain. Maybe you have body hair. And if you think about, how Dr. Charles is describing the body hair, it's male pattern body hair. It could be on your jaw. It could be, between the breasts. And these days when everyone's taking pictures with bathing suits on or going to proms, really it can have very strong mental and emotional consequences. And this has been studied and supported in the science. But Dr. Braverman, maybe you could talk to us a little bit about the fact that, what are the mental and emotional consequences of having PCOS, and how best to deal with them. I guess a little bit depends on the age you're diagnosed and if you're attempting fertility or not.
Yeah. No, I think it's a great introduction, because there's a lot that goes on for patients with PCOS, and when you look at all the different things that are often associated with PCOS, the weight, the hair, all of that, I mean, that goes directly to body image. Also, I think the frustration of not being able to lose weight, of sort of feeling like that's not within your control. And so what we see is, actually, if you look in the literature, we see greater incidence of both depression and anxiety in people with PCOS. I know that nutrition, exercise, all those things become a different kind of focus excuse me, in people's lives. I mean, normally we're doing it just for health, but this is now to sort of fight this silent syndrome that you have. And I think that goes along with the fact that most people don't understand it. Most people have not heard of it. And so, if you take the fact that for most women, body image, self-image is already something that they struggle with. I mean, I feel on some days I'd say 100% of women, but I don't think that's a fair number, but it just feels that way. And you add all of what goes on with PCOS, then it really puts the struggle front and center. And I think for a lot of women, they're also feeling isolated. Excuse me, I'm so sorry. I think, when you try to also then do family building, if you're already feeling different and apart, and then you add infertility, and we know what's the number one feeling that often goes with infertility, feeling, that you're feeling alone, feeling isolated. You're now just doing this in stereo. So it's like, I wasn't happy with my body to begin with. Now I'm moving on to at least doing what, every woman should be able to do. And now my body's not, my body's failing me again.
Right. And maybe one more thing that we just aren't doing right, or one more thing against us, or whatever the story is that we kind of tell ourselves when we're going through this, where we feel somewhat flawed or less than. So there's the physical appearance, there's the tendency towards all those things that we showed before in terms of the metabolic consequences that Dr. Chalice was describing, and now, the infertility. And sometimes, obviously, if people have been on birth control pills for years and they go off of them, I think the hope is that they're going to be okay, and hopefully there's a reset. But if they're not, did they end up delaying, quote unquote, when they shouldn't have, or kind of all those other things, that we're thinking about. So how best can we, as friends or family members, support those with PCOS? What can we offer? I always tell people, if I'm working with them on their diet, and I don't mean like dieting, I mean what they're eating, just nutrition, that if somebody says, how can I help? It's really helpful if the whole house, and not just the person who has PCOS, makes some dietary changes that we'll talk about in a moment, so that person is not kind of in isolation or doing things. It's hard to do in a college dorm, certainly, I can tell you, but in the house, that would help. Do you agree? And are there any other strategies that we could use?
No, I couldn't agree more. I mean, look, it's making that shift for saying we are doing this for health rather than, this is a diet. This is my PCOS diet. It is approaching to say, how are we going to be as healthy as possible together? And so it's not making all the I never can and I shouldn't and all the punishing sort of the punitive thoughts that we have. I'm weak, but rather trying to say, how do we all live this lifestyle that supports all of us? I think as a friend or a family member, it's also sort of listening and believing and not doing what we often will try to do reflexively, which is, let me fix this. You can't fix it. You can listen to the frustration and support. I think I always like working with PCOS patients, partly because I'm a type 1 diabetic. So, I have spent, I hear all the time about, people will jump in and tell me things I should or shouldn't do. And it's like, okay, first of all, you haven't a clue. And just that frustration of almost, shaming. It's funny, I have a flyer in my office that I developed saying the 10 worst, the 10 things you shouldn't say to somebody who has diabetes. I've also done it for infertility, and I haven't printed it, but I've done that with patients for PCOS. What are the 10 things that just make you rip-roaring mad? And it shows that people don't understand. And so, with family members and friends, I always encourage ask, get educated, listen, and don't be dismissive. But that's hard. Not every, we don't always have people that are willing to do that. And so some of that is working through the feelings of saying what I have to do for myself, what happens when people disappoint me, and sort of that management. In some ways, you see the echoes between infertility and PCOS a lot.
No, I think that excellent said, Dr. Braverman. I think that the challenge that we have as reproductive endocrinology and infertility specialists is that by the time the patient comes to see us for infertility, they have been trying to conceive, they're beyond frustrated, and then we see them, and if they have a BMI, a body mass index of 40 or 35 to 40 or above, borderline hypertension, pre-diabetes, and we even suggest that we should probably get a little healthier before pregnancy, that is not received well. So this has to be done at the gatekeeper, essentially, the primary care physician that sees the patient for any other reason, or the OB-GYN. But by the time they see us, we are viewed as an obstacle to their life's dream, and we're standing in the way. So when I talk about if their BMI is significantly elevated, sensitively and gently try to encourage a healthier lifestyle. I try to say this is not a punishment. This is a prescription. It is part of the treatment for this condition. But I think that, it's great that Dr. Braverman is here. I have a clinical psychologist as a direct part of my practice, because there's such a psychological component to the devastation of infertility and the devastation of having this condition of PCOS, particularly with elevations in body weight. And it needs to be that kind of multidisciplinary approach, because it's not, oh, okay, just lose weight and I'll see you back. That would not only not be taken well, that would be inciting anger. We really encourage our patients to talk to our clinical health psychologist about this, but it is a very difficult road. And understandably, as I said, by the time they come to see us, they know what they have and they're over it. They're ready to take on a pregnancy. And, unfortunately, when we see such risk, that's hard for us as clinicians to disregard that.
Also, that, one thing you were saying, Dr. Chalice, is that really in these days, I think we feel like we see something and we can fix it. And you take this medication and you're okay. But PCOS is something that you have to manage the rest of our lives. I mean, it's not something that you can just dismiss or fix with any pill and any kind of
there's no cure.
Right.
There's no cure.
And
it's a management.
Yes. And so it took me, honestly, like probably 4 years to come to terms with the fact that this is something I was going to manage for the rest of my life. And honestly, I ended up being better off because my gestational weight gain, my weight gain during pregnancies was not excessive because I figured this out in my 20s, but my 20s sucked because I had to figure this out. Because it took me like 5 years of like bad eating choices and bad dating choices, by the way, but that's another talk.
Dr. Braverman, I'm sorry, Monica. Dr. Braverman, how would you recommend as clinicians we address the need for improving lifestyle and behavior modification? By the time they come to see us, understanding that setting that we're in.
Yeah. I think you have to, first of all, acknowledge how hard it is, that this isn't a failure on their part, that this is a lifelong condition. And I would talk about, I can't imagine how it must feel to be dealing with PCOS and now not being able to get pregnant. And, you name the feelings, because otherwise you're in that position of, what do you know? I mean, one of the reasons why I get a lot of referrals for both type 1 and type 2 diabetes is that the endocrinologists that refer them to me know that the patients aren't going to say, you don't understand. It's like, yeah. And the same thing, Monica, for you, it's like, no, I'm a badge wearer, so I think
the bracelet.
Yeah, I wear a t-shirt, but it's not a good look. Yeah, so I think, as clinicians, being able to say, I recognize that this puts us, I don't want to put us in an us and them situation. I bet you have been working as hard as you can, and it's super frustrating to be sitting here and then still hearing, this is what prescription I'm doing. Same way, if you were hypertensive and I had said, okay, I want you to have less salt in your diet, and that's like, you're the person who lights up at adding salt into your diet. I think it's just trying to normalize saying, you're not a bad person. We're not against. How do we partner together to make this better? Let's look at what you can do. What are you willing to do? It's interesting. I do a lot of work with medical students, and I teach motivational interviewing. And I really think a motivational interviewing approach is the best way of saying, what would make you consider doing a lifestyle change? And we all know with patients going through infertility, if you say this might help you get pregnant, that's a strong motivator. So what can we do to capitalize on that? How do we do that? I mean, I always tell my patients the only reason why I exercise is so that, I can watch television, because I walk on a treadmill in the basement. I don't have to share the remote with anybody. So it's mine for the amount of time I'm walking. And the second is, it lets me feel a little more comfortable when I'm eating. I mean, I don't go into all the other details, but it's like, what is it that's going to make you do it? What's the reason? For some people, it's like, oh, I want to get into my bathing suit. That's, okay, great. That's wonderful. But I think when you're talking to a patient that's there for other reasons, what's the motivation? If you have kids, I want to be around as long as I can for my kids. So I'm going to be healthy. That I can connect to. I can't do it for me, but I can do it for my kids. If you don't have kids, this will help me get to that goal. So it's helping them identify, in sort of in that motivational interviewing way, what are you? Am I telling you to lose weight, eat better, we all know that. But how do we partner together? I don't know if that's
And also, Dr. Braverman, maybe just identifying some barriers, some common barriers, because if you're in a dorm and everybody eats a certain way, if you're in a house where everybody eats a certain way and it's different. And the other thing is, food is community, food is love. I grew up Italian, like food is the way in cooking that you express love. And for some people, I think, feeling like they're taking that away, or if they live in a place that's not safe to go exercise right outside the house and you can't go to gyms right now, I think it's also like, saying, what are the barriers, and identifying those, and then maybe coming up with a plan for making, good sleep, good exercise, and good nutrition work with those in place. But just even acknowledging, like you said, like, here's what you can do, but here's the stuff that's in the way, and acknowledging for them that they've probably tried this at least a couple of times.
Right. So to get away from that success or failure and just say, how do we keep doing it. It'd be like saying, I've learned everything I needed to in school, which nobody would agree with. But it's like, now I don't have to learn anything more. I don't have to listen to anything. I don't have to read it. No, it doesn't work that way. And recognizing the barriers. So, COVID, for example, is a huge barrier. You're at home, all the barriers of, in the city, it doesn't feel particularly safe to go out. Right now in Philadelphia, in case you're interested, it's like about 100 degrees and about 120% humidity. It's just nasty out there. And people aren't, they're not motivated to go out the door. And you're not going to try to say, oh, just, turn that frown upside down. So I think what we have the ability to do with the voice of authority is to affirm how darn hard this is, and say, okay, and because it's hard and because there are these barriers, and if it was so easy to lose weight, you would have done it by now. How do we figure this out together of steps you can take? So is it talking to somebody like Monica, getting yourself a coach so you don't have to do it on your own? Is it important to recognize the feelings of just sadness and frustration and jealousy of, how come my friends don't have to do this? We play the game, and I play the game with my fellow type 1s of, if they ever found the cure for diabetes, what's the first thing you'd eat without guilt? So if we ever found the cure for PCOS, what would be? And then saying, okay, it's all right to feel sad that you can't just do that.
I love the coaching idea. I do think that I agree with you, Mark, that people really see us at the end of the road often. We wish they would see us much earlier. And I do feel like saying, maybe just even just start with a couple sessions with someone like Monica. Someone who's, they've seen nutritionists, they've been to Weight Watchers, they've done all these things, like seeing a nutritionist and having them tell you, have this many carbs and have this much protein, that's not really helpful. You need somebody who can inspire you and motivate you and come up with really practical solutions. How do you shop? How do you cook? Or if you don't cook, how can you still eat healthy? I was
a PCOS coach.
Yes, exactly. And, and Monica, I know, is doing a lot of work like that. Right. Like Monica, it's about a lot more than just telling people what to eat. It's approaching your lifestyle.
Right. Your hunger and satiety is one thing. And the other thing is a lot of people eat to fix problems that food doesn't fix, food can't fix. And I'm the same. So you have to replace that, whatever that food gave you, that feeling, with something. If you just take the food away, it doesn't become sustainable. So a lot of the stuff that I work on is that.
As a physician, I like to try to give people permission to ask for help. So by the time they're to us, at least they've acknowledged that they have a problem. And that's often the point where people feel like, yeah, I've suffered by myself for so long and I'm supposed to do this by myself, but maybe they need somebody there's nothing wrong with like an expert who has some experience in this area to hold your hand and just make it a little bit easier for you. And it's also helpful for us as doctors. Honestly, I feel like my patients that have food coaches are a little bit less stressed, a little bit more, have more bandwidth to be able to absorb what I'm telling them because they have another resource to lean on. So I like to surround my patients with a whole team if they're open to it, because I feel like PCOS has to be a whole, you kind of need a village to help you because there's a lot to address.
That multidisciplinary team, absolutely.
Can I just ask a quick question? Is PCOS hereditary at all? Because my mum has it, she thinks her mum had it, and so I've just always thought it was.
Well, there is a genetic component to it. There are genes that are being looked at and studied in association. There's 2 subtypes that have been identified, as I said earlier, in the PLOS Medicine Journal this year. it's multifactorial with inheritance, because there's also a theory.
Seems to be like some epigenetic factors as well, like you alluded to.
In utero, yeah. When inside mom, yeah.
Which also makes things kind of familial as well, but it's not straight genetics, but epigenetic, where the uterine environment turns genes on and off or affects their functioning. So it's complicated.
Mm-hmm.
So we
isn't it always?
Seriously. I feel like we need to maybe do another
but I think
like a talk on self-care and nutrition or stress release.
Yeah, we have to do another, maybe another aspect of PCOS on another session.
Yeah, because we didn't get to go over some of that stuff to do about insulin sensitivity. Before we go, Dr. Chalice, can you tell us a little bit about your book, what the name of it is and where we can find it?
Oh, thank you, Monica. I appreciate that. It's the Fertility Doctor's Guide to Overcoming Infertility. And it's at Amazon or wherever you obtain your books, Barnes & Noble or in the US, Target. So you can get it easily online. And I actually posted to all of our viewers the website for the Amazon link. Thank you so much for mentioning that.
I think that if it's anything like you are, Mark, because every time I hear you speak, you know, Dr. Trellis and I do a lot of events together, and he's always very wise and informative and easy to understand. So I'm sure the book could be a great resource. So.
And can you put your handles in there, Dr. Trellis? I know you're pretty active on Instagram, LinkedIn. Do you mind just typing that in the chat before we conclude? Because you write a lot of blog posts and answer a lot of questions, like quick little snippets too. People
sure.
There.
The book it talks about also my personal journey. My wife and I went through this for 10 years, and we went through multiple IVF cycles, and tremendous heartache. So I've not only talked the talk with my patients, like Dr. Bredman, I'm walking the walk. So I've never forgotten what it was like to be on the other side of the fence and with your face pressed up against the windows of families. That feeling has never left me. So my wife and I adopted our 5 little angels, and that part of the story is in the book. But it's also, the book is about hope, encouraging, empowering, and guiding women through their journey. They're all fertility warriors, and our credo at our office is hope is have only positive energy. So we try to inspire and certainly a lot of empathy. And I try to use the book as a resource for them along the way.
And I think that's what Tracy and Sarah have done with IVF Babble. So, and these COPE talks. So I'm just so happy to be a part of that. So thank you, Tracy and Sarah, too.
Absolutely. Kudos.
It's an honor to have you guys. And it means so much to, just get this information out there. So thank you.
Sarah, anything to say before we go?
Just that I'm going to watch all of this, listen to this all back again, because it is just, there's so much to take in. But I feel so sorry for myself that I didn't know this before I started my fertility journey. I think,
you're going to be healthier the rest of your life because of being more informed, and maybe we'll talk some more about PCOS in another session, right?
Yes, amazing.
Yeah. Part 2.
Yeah. You're all so clever and brilliant.
Oh, thank you.
Serena loves it when I call her brilliant, don't you, Serena?
I love it. That's why I'm just waiting the whole time for Sarah to say brilliant. Yes.
You're still waiting for your badge, aren't you? Your little pin. I promised I'd make you one, and I haven't.
Well, thank you, everyone. And I guess it's recorded. We'll put out a link in a couple business days of where you can access this and the other COPE talks. And thanks again for everybody that joined us today. It's always such a great discussion. Everybody on here is such a wealth of knowledge and information. Thank you so much.
My pleasure. Thank you for the honor, for the invitation.
Thank you.
Thanks, everyone.
Love you very much. Lots of love.
Bye-bye.
Bye.
Bye.
Bye.